بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. محدثكم فيصل الغانمي، معيد بقسم المخ والأعصاب بجامعة الملك عبد العزيز بكلية الطب بفرع رابغ. So our lecture is cranial neuropathies, and it is made by Dr. Haytham Tayyib, and it is narrated by me, Faisal Al-Ghanmi. So as a start, we want to revise the cranial nerves anatomy. So as you see, this is the brainstem, an anterior view of the brainstem, and the brainstem is subdivided into the upper part, which is the midbrain, and the middle part, which is the pons, and the lower part, which is the medulla. So cranial nerves number 3 and 4 are originating from the midbrain, and cranial nerves number 5, 6, 7, and 8 are originating from the pons, and cranial nerve number 9, 10, 11, and 12 are originating from the medulla. And also, before we start, we want to revise the symptoms and signs of elevated intracranial pressure, which are so the symptoms and signs are headache, altered mental status, nausea and vomiting, papilledema, visual loss, diplopia, and finally Cushing's triad, which is characterized by hypertension, bradycardia, and irregular respiration. So we will start with optic neuropathy. Its symptoms are reduced visual acuity, reduced color vision. Sometimes there is pain in the eye, sometimes there is no, and there are other neurosymptoms, and the importance of asking about onset and progression. So it is very important to ask about onset and progression, especially in multiple sclerosis, and we will talk about this later. So what are the causes of optic neuropathy? We have ischemic. Specifically, we want to talk about anterior ischemic optic neuropathy. So what is this disease? This disease is characterized by sudden, unilateral, painless visual loss, and it has two types: arteric and non-arteric. So the non-arteric is more common than arteric. The non-arteric is caused usually by its main cause is the drop in the blood pressure. So there is no sufficient blood flow to the optic nerve, and the risk factors are sleep apnea, anemia, sometimes blood loss. So these are the risk factors, and also it is characterized by the patients by presenting with, as I said, sudden visual loss, unilateral and painless upon wakening. So when he wakes up from the sleep, either from sleeping at night or from a nap, he will present with the visual loss. Arteric is caused by a disease called giant cell arteritis. It is the inflammation of the middle and large arteries or large vessels, and it is less common than non-arteric. The point about arteric is you have to give treatment as soon as possible to prevent the progression to the other eye. And we have the inflammatory causes like optic neuritis. We have the infiltrative causes like leukemia, lymphoma. We have metabolic causes like mitochondrial disorders. We have compressive causes either by primary tumor or by a metastasis from other place, or meningioma. other causes like hypertension, anemia, or some medication. And this table is demonstrating common pupil abnormalities. For example, the left oculomotor nerve palsy or left third cranial nerve palsy. So as you see in the dark room, both eyes or both pupils are dilated, but when we shone the light in the affected eye, it still it is fixed, and it is dilated. Even when we shone the light in the unaffected eye, it's still fixed. It is still dilated. Also in the left Horner syndrome, it is the opposite. So the affected eye is constricted. The pupil is constricted. Even when we shone the light, when we shone the light, it is the constriction is more, and it doesn't affected by consensual response. Also in the left afferent papillary defect, this type of defect where when we shone the light in the affected eye, it is dilated, so it is abnormal, but there is a consensual response. So when we shone the light in the unaffected eye, it is constricted. And the last one is benign essential anisocoria, which is there is a difference, fixed difference in the pupil sizes. So normally a person has the same pupil size, but in anisocoria it means that the pupil sizes is not the same for the two eyes. So it is fixed because it is it doesn't affect it, it's not affected by the light. So when we shone the light on it, it is the same even when we shone the light in the unaffected eye. Okay, so now we want to talk about the inflammatory cause of optic neuropathy, which is optic neuritis. So optic neuritis is inflammatory demyelinating. That means the myelin sheath that is around the axons of the nerve cells is damaged, and it is usually acute and monoocular. That means in one eye only. Of course, it presents by visual loss. So unilateral visual loss, and it is acute. So it is associated with the risk of developing MS. Multiple sclerosis. So what is the risk of getting MS after optic neuritis? So if some patient has presents with optic neuritis, right? So what is the chance that he can get multiple sclerosis? So 30% in the first 5 years, and 40% chance he will get MS in the first 12 years, and it will jump to 56% in the 10 years if there is a lesion in the MRI of the brain, and it will be less if there is no lesion in the brain, in the MRI of the brain. So what is the treatment of optic neuritis? It is either corticosteroids, specifically IV and IV methylprednisolone, 250 milligram 4 times per day for 3 days, or 500 milligram for 5 days, then followed by oral prednisone, which is 1 milligram per kg per day for 11 days with a 4-day taper. So what is the benefit of corticosteroids? It accelerates the recovery of visual function, but it doesn't affect visual outcomes. So it is the same. So when we have two patients with optic neuritis, one patient took corticosteroids and the other he didn't take anything, so the outcome will be the same, but the recovery time will be faster in the patient who took the corticosteroids. And also, other benefit of corticosteroids is it reduces the risk of conversion to MS, to multiple sclerosis, within the first 2 years. I mean by that, uh, you know, optic neuritis, it doesn't mean that person has multiple sclerosis, but it is but it is very common that patient could have multiple sclerosis, so that corticosteroids is very good to reduce the risk of conversion to multiple sclerosis in the first 2 years. There are also other treatments that can delay multiple sclerosis in patients with high risk. What are these treatments? It is interferons, fingolimod, and ocrelizumab, and others. So, let's talk about multiple sclerosis. Multiple sclerosis is a demyelination in the central nervous system. So, the disease is only affecting the central nervous system, and it affects the myelin sheath of the nerve cells. And this disease is very common in young adults, female more than male, and presents with recurrent attacks at different CNS locations. That means it has it could happen so it presents with recurrent attacks. That means it could happen in bouts of time, right, and in different places. So one of the cardinal feature of multiple sclerosis is that you have to understand is that it is a disease of that happens in different places and at different times. So patients with recurrent attacks at different CNS locations. So for example, patient could have the first optic neuritis, and then after some time it may resolve, and then the disease may affect the brainstem and could lead to ataxia, and sometimes could affect the motor system and could lead to to weakness, for example, or it could affect the sensory pathway and could lead to, for example, paresthesia or tingling sensation. There are subtypes of multiple sclerosis. The most common one is relapsing remitting, which is that I mean by that is that the symptoms happens and then remit. That means it's resolved and the patient becomes normal. For example, if the patient presents with the visual loss, so it takes time, then the vision becomes normal, and then for some times, and then it relapses again, and then it remits, it's resolved, and then it relapses again, and it remit. So I mean by that is the visual loss is there, and then it got improved, and then it come back, and then it remit again, so it resolved again. Primary progressive is that the disease is happening one time and it is increasing without remission. Secondary progressive is that first it resolved and then it start to progress. And progressive relapsing is that it is it came back. I mean, it result for example, if the patient has vision loss and then it resolved, but then uh, it progressively relapsing. That's mean every time the symptom or the lesion will be more than the the previous relapse. So um, it's not like relapsing remitting where the lesion is completely resolved and then come back. So what are the diagnosis and prognosis and treatment of uh, multiple sclerosis? We diagnose it by MRI and CSF. So in MRI we see the white matter lesion or white matter plaques, and CSF it's not very specific, but we could see the autoantibodies that is high um, because of the there is an autoimmune disease, right? Um, so what is the acute treatment of relapses? So when the so this is acute treatment. So we give steroids. So a patient came with visual loss, we give steroids, and then when he's in remission, in the remission phase, we give preventive disease drugs like interferon or fingolimod and ocrelizumab. So these are preventing agents, and this is an acute drug. So what is the prognosis of multiple sclerosis? It is variable depending on the subtype, but there is high risk of disability with accumulating deficits. So now we want to talk about the other. So I want to talk about the field cuts. This is very important in the cranial neuropathies because you can diagnose many. You can locate uh, the the field cut uh, depending on the vision loss. So for example, as we see here, this is the temporal field and this is the nasal field, right? This is right eye, so this is the right temporal field and this is the right nasal field, and here this is the left nasal field and this is the left temporal field. And as we know, the um, the right temporal will go in the same way, so through the retina, then in the optic nerve to the optic chiasma, then to the optic tract, then goes to the lateral geniculate nucleus, and then through the optic radiation to the occipital lobe. This is the same as the left temporal. So temporal pathways are going in the same way. However, okay, sorry. In the nasal pathway in the right eye, it goes the same way. So the nasal pathways goes in the same way without decussating. But in the temporal way, temporal field, right? Temporal field, it decussates. That's mean it is coming from the right eye and then goes to the optic nerve and then decussates through the optic chiasma to the until it reaches the left lateral geniculate nucleus, and then goes down to the to the occipital lobe. So every cut is presented by a certain vision loss. For example, when the cut here is in the retinal, in the in the retina or in the macula, there will be macular degeneration in the affected eye. For example, as you see here, it is blackish, so that's mean as the central vision is affected, but peripherally and the other eye is normal. And when the the cut is in the, or the lesion is in the optic nerve. For example, this is in the right eye, so the whole right eye is affected, and it is blind, and the left eye is normal. And for example, in the third one, which is here in the optic chiasma, as we see here, the affected is only the, as we say, the temporal, so we call it bitemporal hemanopia. And in the in the sixth, which is in the optic tract, we have the right temporal and the left nasal pathway, left nasal and right temporal, so we call it right homonymous hemanopia, right? And then in the eighth one, which is here in the optic radiation, so it is cut in the upper quadrant, so we call it, for example, this is the right, so right homonymous superior quadrianopsia, or quadrianopsia, yeah. So I know it's a difficult name, but you have to revise it, and it will be easy when you see the location. The same goes here in the ninth, in the lesion number 9, which is here also in the optic radiation. It is the same, but it is in the lower quadrant, so we call it right, because in the right side, right homonymous inferior, not superior, right? So right homonymous inferior quadrianopsia. This is, as we said, the nucleus of oculomotor of the, for the third, fourth, and sixth cranial nerves. So this is the nucleus of the cranial nerve number 3, and this is the nucleus of cranial nerve number 6, abducens, right? So this is only so that's why you have to know where is the location of the nucleus. And then we want to talk about the oculomotor extraocular muscles, which is superior rectus, medial rectus, inferior rectus, lateral rectus. It is very easy. Lateral rectus is moving the eye to the lateral side, to the temporal side. Medial rectus is moving the eye to the nasal side, and superior, it moves the eye to the up, I mean to the superior side, and then inferior rectus move the muscle down. And then there is the superior oblique, which enters the eye to the down, so it makes the eyes roll or enters and down. And there is inferior oblique, which do the opposite, which is extort the eye, or extorts the eye to the up. So this is the extraocular muscles, and now we will see which nerve is innervate these muscles. So the lateral rectus, which is this one, is innervated by abducens nerve, which is cranial nerve number 6. So it does what? Abduction. Abduction is in the lateral. Abduction is the movement to the lateral side. And then the superior oblique, which is this one, which moves the ocular, or the eyeball to the down with intorsion. So this is innervated by trochlear nerve, which is cranial nerve number 4, and the other muscles are innervated by oculomotor nerve. So medial rectus, superior rectus, inferior rectus, and inferior oblique, right? Medial, superior, inferior, and inferior oblique. So this is a case uh, that I want to think about it. So there is a, wait a minute, yeah, so 24 years old female with diplopia. Okay, so with double vision, diplopia is vertical and binocular. That's meaning in both eyes, and there is droops of the eyelid, and there is headache. Past history is negative, and systemic review is negative. So what questions are important in the history, right? And what will you look for in exam, and what investigation do you want to order? So this is like a homework. Think about it, and please answer it to maximize your understanding. So this is, yeah, so this is a typical picture of cranial nerve, for third cranial nerve palsy or oculomotor nerve palsy, where the affected eye is it's in sorry, I mean يعني بالعربي نازلة على تحت, and in the same time it is going somehow laterally, right? So it is in the lateral side and down. Why? Because if you think about it, because the third cranial nerve is not working properly. Sorry. So only the fourth and sixth nerves are working good. So the fourth, the tracheal nerve, is the superior oblique, so the eye is going a little bit down, and the abducens nerve, which is the sixth nerve, cranial nerve, is making the eyes going laterally. So this is oculomotor nerve palsy, and there is ptosis, because this is one of the main features of this is one of function of the third cranial nerve, that is innervate the eyelid. So there's innervates the levator muscle. So there is ptosis because it's not innervated, it's not working properly. And what else? And sometimes, as you see here, the pupil is not constricted, it is somehow dilated. However, the third cranial nerve, one of its function is to constrict the pupil, but here it's not constricted. Why? Because it depends on the cause of the third cranial nerve palsy. So as you see here, this is the third cranial nerve palsy. So cranial nerve number 3. So cranial nerve number 3 is when the cause of the lesion is by for example hypertension or diabetes. So the lesion is from inside. So that's why it is before that, the superficial surface of the cranial nerve is innervated by parasympathetic pathway. So the parasympathetic pathway, it is the main responsible for the constriction, right? So pupil constriction is innervated by parasympathetic pathway, which is in the in the surface, right? So when the problem of when the lesion is coming from inside, the surface is not affected, right? Because it's from inside. For example, ischemia because of the diabetic retinopathy or whatever. So what is happening is that all the function of the cranial nerve number 3 is got affected, except for the constriction of the pupil, because of the parasympathetic pathway is preserved. However, for example, aneurysm, because aneurysm coming from the artery, right? So this is posterior communicating artery. When the aneurysm is compressing, the third cranial nerve number 3, you will see above the in addition to the symptoms that we talk here, that we explained here, ptosis and lateral deviation and down deviation. There's also there will be also construction of pupil. So when you see a patient with third cranial palsy, third cranial nerve palsy, and there is pupil constriction, you have to really consider an aneurysm or a vascular or compressing lesion. However, if there is no constriction of pupil, so then you will think about something from the inside, for example, like for ischemia caused by hypertension or diabetes. So Horner syndrome. Horner syndrome is characterized by three things, by many things, but the most common is three things: pupillary constriction, and ptosis. The eyelid is going down, and anhidrosis. The anhidrosis means there is loss of sweating. تعرق، ما في تعرق. So هذه الثلاثة symptoms is very characteristic of Horner syndrome. Horner syndrome, it has many causes. It could be caused by carotid artery blockage or restriction, or sometimes by other causes. This is not so here is the etiology of Horner syndrome in the adults. So for example, as we said, there is internal carotid artery dissection or aneurysm or thrombosis. This may cause Horner syndrome. Or maybe cavernous sinus lesion, for example, there is tumor. Or if there is in the hypothalamus, maybe there is stroke or tumor. So even in the first order neurons or first order in the central nervous system, maybe there is maybe cause Horner syndrome. In the brain stem, the lateral medulla maybe can cause the Horner syndrome, for example, stroke, demyelination, or tumor. In the spinal cord, there is also trauma. And maybe in the second order, for example, in preganglionic, maybe an apical lung tumor, Pancoast tumor. This may cause obstruction and then could cause Horner syndrome. Also subclavian artery aneurysm. Sometimes thyroid malignancy can also do obstruction and cause the Horner syndrome. Now we will talk about the trigeminal nerve, which is cranial nerve number 5. As you know, it has 3 branches. Sorry, I forgot it. So the mandibular, right? Mastoidal, or so this is V3, which is mandible branch, mandibular branch, and then the mastoid branch, or the V2 and the V1, right? Sorry, I forgot its names, but I will revise it. And in the hearing, there's the cranial nerve number 8, and sometimes 9 and 10. Anyway, so trigeminal nerve. So one of the cardinal disease, or one of the common diseases that cause that affect the cranial nerve number 5, trigeminal nerve, which is trigeminal neuralgia, right? So what is it? It is irritation of trigeminal nerve. What is the clinical presentation? It is electric shock-like, unilateral, and rarely bilateral. So it's most commonly unilateral, electric shock-like. يعني كأنه صعقة كهربائية، ألم كهربائي تيجي في جهة واحدة، في واحدة من البرانشز حقت التراجيمال نيرف. So provoked by wind من الريح أو touch من اللمس or talking sometimes البيشنت نفسه يتكلم or sometimes brushing teeth when the patient is brushing his teeth. So episodes typically occur several times daily and last seconds to less than 2 minutes. So this is very cardinal feature, which is lasts for seconds to less than 2 minutes. In idiopathic trigeminal neuralgia, physical examination is generally normal. Concern for structural causes of trigeminal sensory loss or motor dysfunction. So if the physical examination is normal, this is mostly idiopathic trigeminal neuralgia, but you have to be concerned if there is sensory loss or motor dysfunction. In older patients, it mostly be idiopathic, maybe vascular compression cause demyelination of trigeminal nerve. In young patients, should raise concern for potential structural lesion, for example, multiple sclerosis or aneurysm. So always in young patients, you have to be concerned about multiple sclerosis. Investigation, you will do MRI brain and MRA, and you will have to consider other workup if there are other neurological symptoms. Treatment is gabapentin and carbamazepine, which are anti-epileptic drugs, right? Surgery may be indicated if the pharmacological treatment is not successful. Sorry. So this is a case. This is very good case. You have to think about it. So there is a 34 female, has acute unilateral drooping of whole left face and can't close. Sorry, this is a typo. So it is can't close her eyes or her eye. So also there's no neurological symptoms, ear problem or systemic illness. She's free of that, and there is a throat infection 2 weeks ago. So she had an infection 2 weeks ago, and there is numbness or pain in the front or behind the ear, and there is increased hearing on the left side. Okay, so think about it. You can pause the video and think about it, and then continue, because we want to see what is it. So this is cranial nerve number 7, which is facial nerve, right? Sorry. Sorry. So there is a very cardinal, or there's very important difference between the upper motor neuron facial weakness and lower motor neuron facial weakness. So upper motor neuron, it is usually caused by, for example, stroke or aneurysm or whatever, or tumor. But in the lower motor neuron, it will caused by, for example, Bell's palsy, and we will talk about this later. So because of the, as we see here, because of the upper motor neuron is innervates the upper and the lower, and also there is, for example, from the so again, the right cortex is innervate the left upper and lower face, okay? And then the left face, the left cortex is also innervates only the upper face. So when the lesion is in the upper cortex, upper motor neuron, right? So for example, this is a lesion of upper motor neuron in the right side. So the whole innervation is got affected, is blocked. So the patient here is sorry is that is has lost the lower face sensation. However, the the upper face is not affected because it has innervation from the left cortex. However, in the lower motor neuron type, where the problem is in the lower motor, for example here, so all the pathways are blocked because it is blocked really far away from the brain. So that's why all the face, the upper and lower, is got affected. Okay, so this is a very important thing to know, to differentiate between upper motor neuron facial weakness and lower motor neuron facial weakness. So now we want to talk about Bell's palsy. Bell's palsy, it's named about okay. So Bell's palsy. Okay, so the name is referred to scientist. His name is Bell. So what is it? He discovered that there is idiopathic lower motor nerve number 7 palsy, which is this one. This type, and approximately 60% of patients have a preceding viral illness. Okay, so this is not typically on all patients, but 60%. What are the symptoms? Symptoms are numbness or pain in front or behind the ear, and it is present in about half of the cases. The majority of patients, mostly 90%, will have a decreased ipsilateral stapes reflex. 5% have impaired taste perception on direct questioning, and in 10% there is loss or significant decrease of the ipsilateral tearing or submandibular salivary flow. This is all the function of 7th cranial nerve, so you will not be distracted or you will not forget it, because you know the function of the 7th cranial nerve. You have to rule out Ramsay Hunt, which is the infection by varicella zoster virus of the 7th cranial nerve. Okay, this is Bell's palsy. Okay, so by the way, Bell's palsy is named in our culture by, as you know, Abu G. If you heard that before, Abu G. When patients suddenly have loss of or weakness in the one side of the face, so immediately he thought he has a stroke, but then he got relieved when he knows that it is not a stroke, because it is lower motor neuron disease, right? So full recovery occurs in nearly 80 to 90% of patients. 10% may have a recurrence of Bell palsy, so it could come again. Recovery usually occurs from 4 to 6 months, and mostly by 12 months. Treatment is prednisone, short course of course, and plus or minus antiviral. And the most important is you have to patch the eye, so you have to put a patch on the eye that is affected, because the eye is weak, so it cannot so the patient cannot close it properly, so you have to prevent corneal laceration. So this is maybe a good key to ask you, whether in the exam or in the real life. The last one is cranial nerve number 8, which is responsible for hearing. So we want to talk about central versus peripheral vertigo. So central causes maybe stroke in the brainstem, or cerebellopontine angle lesion, or others. Peripheral causes, most common is benign positional vertigo. There is otolith in another ear, or labyrinthitis. This is a common warning signs of vertebrobasilar ischemia. So when you have dizziness, you could think that the ischemic structure is vestibular nuclei, cerebellum, or inner ear. Read it thoroughly. It's very useful for differentiating the causes of um, sorry uh, to to uh, to know which structure is already got ischemia. For example, blurred vision or other visual disturbances. As we said, either there is in eye movement pathways or in visual cortex. Uh, for example, if there is headache in the occipital area, so maybe posterior fossa, meninges, or vessels, cranial nerve number 10, and cervical roots. The last thing we want to differentiate between central versus peripheral vertigo. So in peripheral vertigo, it's usually in the inner ear, and in the central vertigo there is brainstem. It happens in the brainstem or cerebellum. So nystagmus is very differentiating feature between the peripheral and central. So nystagmus is delayed in peripheral, so it doesn't happens very immediately. However, in central, it happens very immediately. Sometimes it's delayed. Adaptation in peripheral, the patient can adapt the vertigo. However, in the central vertigo, he can't uh, adapt, and he cannot habituate the vertigo. And there is characteristic of nystagmus and vertigo. For example, in peripheral vertigo, there is only horizontal or rotatory. There is no vertical nystagmus, but in the central there is vertical. So when you see vertical nystagmus, you think most likely about central, not about peripheral. Also, the vertigo doesn't change directions, and in the central may change directions. Also, peripheral prominent nystagmus only if vertigo is present as well. So there's no nystagmus unless if there is vertigo. However, in central, maybe there is nystagmus without the presence of vertigo. So until here, I finished the lecture, which is cranial neuropathies. Thank you for listening or for watching. I